you so much. And I know that I stand between everybody probably in the plane ride home or lunch. So, and a lot of you did see a lot of what we talked about before. So we'll move through this pretty efficiently. Disclosures really none related to the presentation, but I am proud to be the president of the ARN Foundation Board of Trustees right now. Why do we worry about it? And we saw some of these studies in the talks by the previous speakers today. When you do 2 sessions on OR fire safety and energy, you're going to find a lot of the same studies show up in people's presentations. But in the Pennsylvania system, we saw that 58% of the reported fires in their database either came from electrosurgery, 38% came from the light cords, and that tells us we need to really be aware. I think Pascal in his first presentation talked about the anesthesia claims database with its injuries, so I'm not going to go in that again. But when you look at the other thing that we have to think about, and we often forget, that there are reports in the literature of unusual situations in ignition from mechanical devices, air conditioners, ventilators, and electrical shorts. And this was in a very brief article in the ARN Journal this year that really talked about some of the concerns about fires in the operating room as well. What did I just do? Okay, I did it. Here it is. Another article we published in the ARN Journal, I have a column that I coordinate, is called Table Talk. And what it does is it's a commentary that brings together perspectives of all the members of the surgical team to talk about how you begin to broker having conversations, or what are the high-level things you might do from each discipline around different issues. We did one on surgical fires a year ago, and Dr. Tio Daggy from Boston, who is the current chair of the CSPS, the Council on Surgical and Perioperative Safety, provided the commentary from the surgeon's perspective. And when he did it, he had a really interesting way of reminding us that we have systemic and non-systemic reasons to understand the risk in the fires. That the system tells us that everything is a risk, that every procedure and every patient is vulnerable, that it's predictable but not unexpected, and that there are some steps around mitigation, which we've all talked about multiple times over the morning. But there's non-systematic ones as well. There's specific situations, specific conditions, and I think electrosurgery and the use of it really falls into some of this area. Predictable as a function of using this high-level equipment, and again, really focuses risks around performing assessments on vulnerable, always being ready for the next event, completing validations of competency around equipment, techniques, and protocols, communications and drills and simulations. And this published in 2014 issue of the ARN Journal as well. So what do? And we saw this before in the previous talk, so I'm not going to spend a lot of time, but I just always say, remember, it's a team process, and the first thing of all is keeping the patients safe. We can make the full slides available for everybody if they would like them after the presentation. And we talked in the last FUSE course about the MAUDE database, the National Quality Forum. Those are important places, and the role of the Joint Commission, and we'll move forward. But let's focus on some questions to ask when you're reviewing an OR fire, not when you're preparing for one, but when you're sitting the team down if you're going to facilitate a debrief around an OR fire. What was the immediate response to the patient? Those are the things you need to pull out of the team. What do they think happened? Were all the alarms activated? Did the team members know their roles? And then how did they carry them out? Where did the fire come from? Were all the safety nets implemented as defined in guidelines, protocols, et cetera? Because you're really drilling down on here, it's not just what did we do today, but how did that system with which we did it in, that facility, that environment, that operating room, how did it function? Do we have systems reasons to say we had that gave us cause to have this OR event? And then what can we do to try to make that not happen again? How well do we contain it? How would you rate the teamwork? And what do we need to do to have it happen again? If you can pull all of that out of your mixed discipline debrief after an event, you really are going to have all of you're going to really need to do to move forward as well. And I did that again, excuse me. You saw, those of you who were here, and I think many of you were, saw this in a bigger version in the last presentation. It addresses how we at Beth Israel Deaconess Medical Center take steps for immediate response. This is our workflow. We check on the patient, we sequester the devices, we report them, we generate safety reports, and we actually move the information to the next leadership level in healthcare quality to get it into the briefing and into the peer-protected system of the hospital. A little bit more here. When it's an equipment and device, this tells us the steps and the workflow to be able to take the device, get it to the right people, the bioengineers, the patient safety people, the risk managers, and ultimately to the industry people. It's important to have this because a lot of people don't think about what am I going to do and did I do everything that I really should do within the construct and the guidelines of the patient safety and the risk management people that are in the facility that you're working in. So every facility would have a different workflow. This is what works for us. I think it's really important, and I just pulled a very small piece out of our fire safety guidelines, that everybody has a guideline that really helps pull out the roles. And you can use this in a lot of different ways. This is the segment of our fire safety guideline in response plan. This is the one around a small fire. I chose this one here because actually it fits best on the slide, and it's a little bit readable. But you can see that everybody has a role, everybody has an expectation, it's clear, and this is where you would build any education around your guideline, any simulations, any drills, anything you were doing to go back and say, how did I respond to a fire? Did I do the right thing? Did everybody work in their role? So I think having those kinds of tools in your fire safety plan is really important. We're happy to share ours with anybody. They can reach out to myself, to Dan, at Beth Israel Deaconess Medical Center, to Paul. We all have access to them and would be happy to get them to you, if you the fire safety policy and guideline to you if you'd like. So with that, we're going to sort of talk a little bit about a graphic. This is a cause map. We use a cause map when we have any failed event that relates to a situation with the patient. It focuses more away from what did we do with the workflow, but it takes us and makes us ask 5 whys about why we're doing it. So we sit down in our debrief, and from the notes we take from the debrief, we create the cause map with the why behind the why behind the why. This is the beginning piece, how you gather the data. The second piece is identifying the root causes, talking about the patient outcome, because any of these type of events do go to what we call our QI directors or whatever high-level review team you have in your hospital. You can put the content into it. This is a single document. It was way too big. It got way too small when I tried to put it individually on the slide. And then what are the corrective actions? I don't like the use of corrective actions. I would prefer the use of action items because not everything is corrective. We used to treat all events by what? Giving somebody an in-service and writing it up in their personnel file, be it the nurse, the physician, or what. There's a lot of work around these things. Many of these things are systems problems, and they need to be addressed at a higher level that tells us we need to do something else. Things like, for example, events and injuries around shops injuries. That's not related to fires, but right now, a lot of shops injuries in the Massachusetts database tell us that there's a lot of injuries going on to our residents and fellows, our trainees. We got to do something about that, or we're not going to have nurses and physicians down the road because we're going to get them all injured while they're learning. So those are systems kind of things that you really want to think about as you move forward. Again, this has been pretty quick for you. I'm glad to put this back into papers, share you anything you want around this. I think that how we respond to our events is really the strength of an organization is measured not by counting all of the successes, all of the great things we do, but by really responding to failures and then taking what you learn, applying the learning broadly, and then coming out at places like SAGES, at ACS, at AORN, at ASA, and sharing your learning in an honest, transparent way, because that's how we all learn together, and I think that's probably where FUSE came from. One thing I didn't see as I sat through most of the morning today is I didn't see anybody talk about the patient safety video that the Anesthesia Foundation has out there. They may have earlier before I got here this morning. If you go on the Anesthesia Patient Safety site, if you're a nurse, you can go there yourself. Anybody can go there. If you're a physician, send your OR educated to it. They have a wonderful airway fire video that they will send out to you free of charge, and it's extremely well done. And just at the Anesthesia Patient Safety Foundation. But if there's any questions, please, I'll be here, come forward, and I wanted to respect your time on Saturday after a long morning of learning. So thank you so much, and thank you for taking care of patients every day.